like, oh, well, this fits with this symptom, or like, I don't know, I'm just like imagining like when you give someone a label, how it changes your perception sometimes of them or your assumptions.
Yeah,
Did
no,
you,
that's a great question. I think if I think back to my own process, early in my career, um, the act of diagnosing was always and is a painful act. It's not a pleasant thing. Um, and probably early on, thankfully, I had really great supervisors, but it took a lot more of my cognitive energy to sort of keep that as one part of who this person is, but not let it sort of seep in and influence my overall perception of the individual. And that's especially difficult whenever people are in acute states, whenever there's maybe a really high level of anxiety or there's maybe a high level of psychosis or those sorts of things. It becomes more and more difficult to see the person first, then the whatever diagnostic label as a part of the person. It becomes more difficult whenever the presentation is such that aspect of themselves tends to come into the room first, so to speak. Does that make sense? Over time, I think what I've learned is I'm going to meet them where they are. And so if they are in a state of crisis, then certainly that's going to be my primary focus. If they're not, let's say that I'm working with a client that I might classify as worried well, or someone who, they've got a job, they're functioning in their life, but they're experiencing some depression or those sorts of things, then their mental health issues are not going to necessarily be as critical, or not, I don't know if that's the right word, or as present in the space. And so, as I've learned, it's sometimes the best way to approach is what's the client coming to me with today? And if they're coming to me with significant mental health symptoms, then how can I help with that? How can I address that? And if they're not, if they're coming to me with, I had a really bad fight with my partner last week, and I want to talk about that, then that's where we're going to go. And so over time, it's become easier for me to see the whole first, and then understand and recognize the part that the mental health symptoms or picture might play in the whole. But I do think it's something that requires a lot of reflection and a lot of supervision. Making use of the supervisory relationship. I think one of the more memorable of those experiences for me, I worked with a lady that, and I'm going to get lost in my storytelling. I worked with a lady that was diagnosed with schizophrenia, um, and she certainly had some very persistent delusional beliefs, and these were incredibly anxiety producing for her. But the beliefs were not beliefs that actually were grounded in any shared reality that we had. And so persistent delusional beliefs that someone was going to kill her. And you can imagine, and this is her reality, this is her sense of truth, you can imagine how stressful that is and how much anxiety that would produce, right? If this is a persistent thing that's part of her life every day, that she has this belief that someone's trying to kill her. So it was really hard for me at first to get beyond that or to see around that in some ways, because it was so present and so pervasive for her. But over time, what I learned is if I can find my way underneath that sort of belief and focus instead on the experience of fear, and find a way to connect to this person based on my own experiences with fear. If I can connect with her around the sort of the emotional content that's underneath whatever the presentation might be, then I have an easier time. It's easier for me to see them as an individual that's experiencing fear. And the fear just so happens to be manifest in this particular way. But I get fear. I understand fear. So how can I connect with that individual around that? And so over time, you find little tricks like that that allow you to hold on to that sort of holistic view of the individual, which is something that we as counselors sort of subscribe to. That, you know, we see people as multifaceted. We see people as existing in their context and all that kind of stuff. And so it becomes easier with time because you'll learn different ways that you certainly meet people where they are with regard to whatever their needs are. And whenever there are those really difficult symptom presentations, you find ways to help yourself acknowledge and honor that and hold on to the holistic picture. So that's just one example of how I did that. But that's a great question, Lauren. All right, are my slides showing up now or no? They are, okay. All right, good. So that's just the laundry list of anxiety and OCD stuff. I have, before we talk about any specific, and let's see if this works. I don't know if this will work now. This is my very favorite. It's like a 3-minute video that I believe to be so useful when we think about anxiety and our relationship to anxiety. So I'm going to take my headphones off and turn on my volume. And let's see if we can make this work. Knock on wood.
Eh bien, mademoiselle, vous avez un crocodile. Oh, vous n'êtes pas la première, et vous serez sûrement pas la dernière. On s'en sort très bien, je vous rassure.
J'en ai marre de toi. Non. Maintenant, la limite, c'est ça. Non, quand même. T'inquiète pas.
anxiety is a blue crocodile. So I think I love that because it's certainly could be used with clients as you sort of think about the narrative idea of externalization. So how can I see this part of myself or anxiety as separate from myself? Anyway, just thought that would be fun to take a quick look at. And so when we're thinking through the different categories or the different diagnoses in this particular chapter, the ones that you're going to see most often, certainly separation anxiety would be in that list. And this is particularly prevalent in children, although it can extend into adolescence and adulthood. So once upon a time, it was actually in the chapter for childhood disorders, but no longer. Mostly because it can extend beyond childhood. So most prevalent for children under 12, decreases with age, certainly attachment related, and usually symptoms are going to be last longer than 4 weeks, or and they cause distress or impairment. And I don't remember. Let me peek ahead. Yeah. So these are the sort of the symptoms, and so all has to do with the major attachment figures. And so whether that be a parent or a guardian or whoever it might be, that would be the primary point of anxiety would be separation from that person.
And parents experience this with their kids?
I'd say so. Yeah, I'd say so. And certainly there can be, even if it doesn't rise to the level of diagnosis, I'd say there certainly can be anxiety that parents experience whenever they are required to leave their children, those sorts of things. But yeah, it can be present for adults as well. And whenever we think about treatment planning, really what we're going to be looking at certainly is working with this family system, right? And reinforcing wanted behavior, extinguishing unwanted behavior, focusing on quality of time rather than quantity of time, because in our culture and in our society, a lot of times separations are unavoidable if we have parents that are working, kids that are going to school, those sorts of things. And so really helping families to focus on quality of time with their kiddos. And then also identification of other sort of external supports that might be present or might be available for families. Attachment-based interventions, I would think, would be really important. And then certainly ideas about sort of more behavioral approaches, CBT approaches, as far as systematic desensitization around anxiety and things like that. That kind of makes sense. So that's probably one of the bigger anxiety disorders that you'll see more often. Others that you may see in childhood situations and then across the lifespan, selective mutism usually has to be present for greater than 1 month, but would include not speaking in social situations whenever speaking is expected. And there's not a sort of a physical issue with actual speaking, right? So they can still speak in other situations, but this kind of an anxiety is going to interfere with educational opportunities, social communication, those sorts of things, but not attributable to any other language barriers. And then specific phobias, and the laundry list of potential phobias is pretty long, but in order to reach the level of diagnosis, then the phobia has to have been present for more than 6 months. There must be an intense fear or anxiety around a particular situation, so much so that the person avoids it, or that the anxiety is out of proportion with whatever actual danger there might be. And then there are different ways to code those based on the type of phobia. So specific phobias fall under anxiety disorders. And then social anxiety or social phobia, and this is another one that I see quite a bit. Again, greater than 6 months, fear and anxiety about exposure to scrutiny in social situations, fear about being negatively evaluated, humiliated, embarrassed, rejected, and it's out of proportion to any actual threat. And in children, this must occur with peers, not just with adults. So if children are only anxious in situations where they're just surrounded by adults, that wouldn't necessarily rise to the level of disorder. Make sense? And then there is a specifier for performance only social anxiety. And so that could be public speaking, or I know when I was a kiddo, I might have been able, I probably met the criteria for this whenever because I played the clarinet, and buddy, my hands would shake. I would get so nervous that I couldn't hardly hold my instrument. I'd get so nervous. But that was a performance related anxiety. When I was by myself, I was fine. So social anxiety is fairly common. Agoraphobia, this is a specific phobia that has to do with a fear of being in situations that I can't escape from. Some of those could include public transportation, a fear of being in open spaces, a fear of being in enclosed spaces, standing in lines, being in a crowd, and being outside of the home alone. So agoraphobia has to be present for more than 6 months. And so the person might require the presence of another person to leave the house, things like that. So it's a pretty intense fear, and as you can imagine, potential for interrupting occupational and social opportunities would be there. Okay, and then we've got panic disorder, which we've sort of touched on a little bit already. This is closely related to panic attacks that we might see as a trauma response. But panic disorder is a recurrent, unexpected panic attacks. Greater than one attack followed by more than 1 month of persistent or concern or worry about additional attacks. Maladaptive behavior change, and then there's also a performance only specifier for panic attacks. Also important to know that there are different cultural views of this. And so in the DSM, there's a section in the back that talks about different cultural descriptions of different disorders. So on the next slide, the panic attack specifiers. So this can occur in the context of other, or can be comorbid with other mental health conditions like anxiety, depression, PTSD, etc. If you code panic disorder, then you would not add with panic attacks as a specifier to another disorder. Does that make sense? And in order to meet the threshold for panic disorder, then there has to be 4 or more symptoms. And so the symptoms are listed here. Questions about that?
Yeah, Ellen, I have a question. When you said the part about it, if panic disorder is coded, do not add with panic attacks to other diagnosis.
Right.
Can you give an example of that?
Yeah.
What you mean, please?
Let's think back to Nyana for a minute, our first CCBTP. So if I were to diagnose somatic symptom disorder for Nyana as a primary, it's possible that I could specify with panic attacks, right? But if Nyana met the criteria for panic disorder, which that would be, let's look back, greater than 1 attack followed by greater than 1 month of persistent concern or worry, maladaptive behavior change, and met the 4 or more symptom threshold, palpitations, sweating, shaking, shortness of breath, etc., if she were to meet the threshold for diagnosis of panic disorder, then I wouldn't diagnose somatic symptom disorder with panic attacks. I would diagnose somatic symptom disorder and diagnose panic disorder. Yeah. So they can be comorbid. They can both exist at the same time. Good question. Other questions about that? All right, a few others. Actually, those are the big ones, I guess. Let me see. Yeah, well, generalized anxiety. This would be actually the biggest category, and you see this a lot. And I'd say that you see this across the lifespan. It's going to present a little bit differently in kiddos than it does in adults. You might not see as many symptoms in kids, or you could see fewer symptoms and that would still reach threshold. Only one of these symptoms would be required in children, whereas more than 3 would be required for adolescents or adults. But basically, GAD, generalized anxiety disorder, excessive anxiety and worry occurring more days than not about a number of events or activities. So it's not specific to a particular activity or a specific time or those sorts of things. It's general. And that lasts for more than 6 months. And the anxiety is difficult to control. So for adolescents and adults, more than 3 symptoms have to be present in order to be diagnosed. Those include restlessness, easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. In kiddos, however, you only need one of those. Does that make sense? Okay. Going back for just a second, when we're talking about phobias, social anxiety, specific phobias, agoraphobia, and panic attacks, and you may remember, those of you that have had behavior therapies already may remember that systematic desensitization is the treatment of choice for phobias, right? And so, and then I included, as a reminder in your module this week, I included a distress scale and what was it? Sorry. Distress scale and exposure hierarchy, progressive muscle relaxation script. So that would be the treatment of choice for the phobias. Okay. But then generalized anxiety, a large category. Right now, rates of anxiety are astronomical. So if you look at this list right now, easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. Anybody experiencing any of those things in the last year? Yeah. So all of us we're probably all sub-threshold anxious right now. Maybe some of us meet threshold, but I'd say that most of us have some level of anxiety that's out of proportion to our baseline, given the current situation that we're in with social distancing and those sorts of things. So how do we work with anxiety? Lots of different approaches. Certainly psychoeducation around healthy eating, sleep, and exercise. So rest, water, movement. Those 3 things. If nothing else, if my clients do nothing else, rest, water, movement, nutrition. I think those are the 4. There's an acronym, but it's not coming to mind for me right now. But helping clients to, even during lockdown from global health pandemic, are we getting adequate nutrition? Are we getting adequate sleep? Are we drinking enough water? Are we getting adequate movement and exercise. So those are the things that are going to help, likely more than anything else, with mitigating the effects of anxiety. Because you guys know, whenever we have that sort of constant level of anxiety, what's going on in the body is that our body is releasing cortisol and stress hormones. And guess what happens when our body constantly releases cortisol and stress hormones? Our other systems shut down, and so we're not functioning optimally. And so certainly psychoeducation around all of those things are going to be really important. Mindfulness is going to be really important. And then as far as intervention strategies, it really depends on your style or your preferred modalities. But CBT, you've got all kinds of strategies you can do. Certainly we can go into existential thinking, gestalt strategies, solution focused, etc. And so the interventions and the treatment is really going to be dependent upon your own style and then where your clients may be as far as how they sort of conceptualize their own anxiety and what would be most helpful for them. Kind of makes sense? Yeah, go ahead, Robin.
I have a question about the symptoms of GAD. Because I look at those symptoms and I think, if you have a client and they come to you and they say they have these symptoms, but they also, maybe they have chronic pain. Like those are very, very similar. And how, like one's a medical and one's like a mental health diagnosis. And is this a situation where, I don't know, I feel like there's sort of a what do you call that when it's like a vicious cycle? Like, is the pain causing these symptoms?
Which came first, the chicken or the egg?
Right. So, and I know in other times of diagnosing, we say like if it can't be better explained by something else.
Right.
So what do you do when you've got a situation like that?
So on my initial intake or my initial meeting with the client, I'm gonna get a sense of when's the last time they saw their doctor. And I'm gonna remember we always rule out medical causes first, right? And so it may be that I can make a provisional diagnosis of anxiety, but I want you to go see your doctor to make sure there's nothing going on that might be important for us to know right now. So, and I can still make that provisional diagnosis, and in my treatment plan, first goal is appointment with medical provider. So I want to, because the symptoms are the symptoms, right? So the restlessness, the muscle tension, those sorts of things are the symptoms. It's not going to hurt for me to provide psychoeducation around the importance of nutrition, sleep hygiene, those sorts of things, because it's likely their medical doctors will do that too. So I can go ahead and do what's the best practice for treating. But part of my treatment planning will be that primary goal, or goal number one, will be appointment with medical doctor to rule out any medical causes for the symptoms. Then once we know that, then I can still continue to work on providing accurate psychoeducation and helping my client develop strategies and skills to manage the symptoms. And as they begin to manage those symptoms, then I can also start to think about, so what are the core issues that are probably exacerbating the symptoms? So I'm not going to go to core issues until I've ruled out medical causes. Does that make sense?
Yeah.
I'm not going to attribute restlessness and sleep disturbance to early childhood abuse until we know that it's not due to some metabolic issue that's happening right now. But that doesn't mean I can't work on helping them to practice strategies for stress reduction and those sorts of things. Good question. Anything else? Other questions? Okay. also wanted to at least mention the disorders that sort of fall under the obsessive compulsive category. And so, still within the anxiety realm, this is another way that anxiety can manifest. So, OCD, you may hear quite often, it can be either obsessions, compulsions, or both that are time consuming and cause distress or impairment. So, a common one would be excessive hand washing, or a, sort of this recurrent urge to check that I locked the door, even though I've already checked 20 times. Check it again, check it one more time. So, there's a compulsion around some particular behavior. So, repetitive behaviors or mental acts that I feel driven or compelled to perform are the compulsive side of that. And then obsessions would be a recurrent, persistent, intrusive thoughts or images that cause me anxiety or distress. So obsessions more along the lines of unwanted thoughts, compulsions more along the lines of driven to participate in particular behaviors or rituals in order to mitigate the anxiety that I'm experiencing. So that's, and they both kind of fit in the same category. Sometimes compulsions are attempts to control obsession. So maybe I have an obsession or persistent thought about my safety, right? And my compulsion is check the door, check the door, check the door, check the door. Those sorts of things. Questions? This is a particular type of anxiety. OCD is also a disorder that often requires medication along with therapy as sort of the best practice treatment. And then we mentioned there's a few other more specific types of obsessive and compulsive presentation. One of those is hoarding disorder. And I know from my work with folks at Full Life Care, where I do some consultation and supervision, this is a terribly difficult disorder to treat. And basically, difficulty discarding items regardless of their value, difficulty discarding, or the act of discarding causes great levels of distress. Accumulated clutter can congest the living space, and you'd also have a specifier of with excessive acquisition, which is about 80 to 90% of those diagnosed. This usually shows up, at least in my experience, it shows up for folks whenever their hoarding behaviors become public health issues. And so a lot of the folks that I'm supervising work with clients that live in public housing, like Seattle Housing Authority and those sorts of things. And whenever individuals have hoarding issues, there may be first of all issues with hygiene and cleanliness, and then there also may be issues with safety if their hoarding behaviors result in the amount of stuff that they've accumulated, preventing emergency personnel from coming into their apartment, or preventing the individual from being able to access windows or those sorts of things. And so usually by the time an individual with hoarding disorder is sort of known to the mental health professional, the disorder is very difficult to treat. In my experience, sort of anecdotally, there is often a very strong relationship with unresolved grief that plays into the presentation that I found. You also see it often with people that have experienced poverty. and that maybe have grown up in sort of those historical or cohorts that the value was you don't throw things away, you save, and those sorts of things. And so you may see it in different sort of age demographics. You may also see it in folks that have experienced a significant lack of control in their environments. And it's a way to sort of assume or exercise control. So those are some of the ways that I've seen it. It's a difficult disorder to treat. Trichotillomania, and this is the recurrent hair pulling. So this is an OCD-like behavior. It's an anxiety-driven behavior, and also can result in a lot of associated shame, depending upon where the individual might be pulling their hair. I mentioned that I used to work with a gentleman that would pull his eyebrows out, and unfortunately, that's a part of your presentation that others will notice. Right? People will notice if you don't have eyebrows, and so for him, there was a lot of shame, and so he would come in whenever he was. And there were only a few times that I recall in a couple of years that we worked together, a few times that he was actually sort of what I would call bald right there. But often his eyebrows were very thin. But to the point of totally bald, it didn't happen all that often. But it did result in a lot of shame for him. And then the excoriation disorder is the recurrent skin picking, to the point of like skin damage or lesions on the skin. Same kind of compulsion toward that. And then one more, body dysmorphic disorder. So this would be, and I want to point out that this is different than gender dysphoria. Okay? The body dysmorphic disorder would be a preoccupation with perceived flaws in physical appearance that aren't apparent to other people. And there may be compulsions or repetitive behaviors that are connected with this preoccupation. Okay? And this is different than eating disorders also. And I want to specify if it's specifically around muscle dysmorphia. And I'd have to look that up again. It's been a minute since I made these slides. I also want to have a sense of the level of insight that the individual might have, whether they have a fair level of insight, or is insight absent, or are they delusional in their belief. Questions about that one? Not one I've got a lot of experience with, or any actually.
Ellen, I was just going to make a point about like 4 slides ago, the OCD one. That's what it's. I don't know if it's that revolutionary, but it helped me to see the word unwanted.
Okay.
And the I think I've often jokingly been like, oh, that's my OCD if I'm like fixing a rock at a place on the pavement or something. And I feel like that really helps clarify it for me and make it a disorder. So otherwise, it's just.
I mean, and we all have traits, yeah. And personality traits aren't necessarily disordered. And so, and we may have sort of desires for cleanliness and order and structure and those sorts of things. But for a disorder, for the level of disorder, then recurrent, persistent, intrusive, unwanted, right? This is not something that I don't want to wash my hands 70 times a day. I don't want to, but I keep doing it, right? Same with locking the door 20 times or whatever it might be. And so whatever the obsessions or the thoughts and the behaviors, the compulsions, this is stuff that I don't want to be a part of my life, but I continue to participate in the compulsive behavior because that's basically the only thing that will reduce my anxiety. Yeah, good point. Thanks, Vicki. All right, let's look at this last slide here. Treatment planning. So certainly helping folks to understand about learned behavior and rituals, importance of hygiene in the case of hoarding, doing work around body image in the case of body dysmorphic disorder, and then also mindfulness in the cases of trichotillomania and excoriation disorders. And so most likely you're going to do a pretty strong CBT approach with any of these particular issues, I think. And really, I think, and maybe some DBT as well, with the notion of distress tolerance, I think would be a way to approach some of this. Certainly we could start to look into existential type themes and the meaning making that people have with regard to their anxiety and their relationship with their anxiety. And then, but I think most likely we're going to start with a more structured CBT approach to start to minimize whatever the symptom presentation is, and then over time we'll have the opportunity maybe to go to core issues and look at psychodynamic or existential approaches that might be helpful. Does that make sense? Okay. So, good. That means we've got our last half hour for our practice case. So I'm going to send you back to your groups here in just 1 second. And your practice case this week is in your Module 7 module. It's called Fears and Worries.